Come on in Facebook, come on in YouTube. Getting ready to start my show called Jimmy Rants. So just getting set up here, about ready to start. So thank you for being here today. Look forward to sharing all about this one. It's always good to have reviews in medical journals looking at low-carb diets and their veracity. And so we got a good one for you here today. Hello, Norma, Robin, Rebecca. Thank you all for being here today. Hello to all my YouTubers. Come on in, make yourself at home. Promise we don't bite. We don't bite too hard, although I am very carnivore, so maybe I do bite a little bit. But thank you for being here. Come on in, make yourselves at home. Hello, Tracy. Thanks for being here. Welcome in, YouTube. Come on in, guys. We're getting ready to start my show called Jimmy Rants over on Instagram. Hello, Mitzi. Thank you guys for being here today. Hello, Kim Call over on YouTube. Appreciate you being here today. So I'm going to come to you guys here in a minute when we're done reading this story, this journal article. But get ready, because we have lots to talk about with this one, especially in light of some of the stories I've been doing lately. This is just underscoring why it's ludicrous that low-carb diets aren't more readily accepted by the culture. Hello, Rebecca. Long time no chat. I know, girl. We gotta talk again sometime. So good to see you here on Facebook. Hello, Pam. Thank you for being here. Hello, Rock. Thank you for being here as well. All right, let's get going. Here we go. Hey, bleh. I can't start over. It's live. Hey, Instagram. I have literally never done that on this show, but you got to click on down there now to see the rest of what this is about. I got a great systematic review of all of the data looking at low-carb diets as it relates to diabetes and obesity. Pop on over to IGTV and you'll see the whole deal here today on Jimmy Rants. JimmyRants.com is the website. I have literally never flubbed up that opening, but I just did. See, I am human. I'm not a robot, you guys. So JimmyRants.com is the website, and as always, if you want to engage live in the content, you really need to go follow me. I'm over on Instagram. I am at Livin' Low Carb Man, LIVINLOWCARBMAN. Once you are there, you can enjoy all the content, flub ups and all, right here on Instagram. We also simulcast live over here on my Facebook page, as well as on YouTube Live. So thank you all for being here today on Jimmy Rants. When the show's over here on Instagram, we do go live Monday through Friday, 11 a.m. Eastern, sometimes 5 p.m. Eastern during the week, sometimes on the weekends. But when we end here today, it automatically uploads over to IGTV. So that's how you can watch it on the replay. It's a recent change that they made. Used to, they left it up for 24 hours on Instagram Live, and it just disappeared. Well, now they got the bright idea, hey, this is good content, we should keep it on IGTV. So now you can access it on IGTV. You can also go to JimmyRants.com, see all the past episodes. We also throw them up over on YouTube. So we do this live stream on YouTube, but we also put all the past episodes up on YouTube. Type in the keyword Jimmy Rants and you will find the show. Okay, you guys, so you know how we often hear that there's not a lot of scientific evidence to support a low carbohydrate diet as it relates to things like obesity and type 2 diabetes. That's what the mainstream narrative has been out there for many years. And thus, because we don't have this evidence, we can't possibly recommend it in things like the dietary guidelines, which we talked about in recent Jimmy Rants. They're ignoring the low carb science. And we're just seeing that there is this ignoring of this messaging, which is odd because we know from experience, so many of us have gone on a lower carb diet, a low carb diet, a ketogenic diet, a carnivore diet, all these diets that cut down carbohydrates in our diet, and we're able to get healthier. We're able to lose weight. We're able to improve insulin resistance. We're just able to see great improvements in all of these what's called cardiometabolic markers. And so if these things get better, how do you ignore that? And of course, whenever you bring that up to people, well, all of you people are just anecdotal evidence, and we don't really have any evidence that what you say is true. And real doctors are not actually using this in clinical practice. And there's where I always say, oh yeah? You ready for me to list off all the doctors that I know, that I personally know as friends, that I have talked to on the Live and La Vida Low Carb show? You want me to kind of go down that list? Because I got a whole list of those people. And a few of them, you guys, are starting to publish some of their findings of what it's like in their clinical practice. So all those low carb, keto doctors, and I don't want to ignore the dietitians and the nutritionists and the nutritional therapy practitioner, any of the people that are kind of working on the front lines using ketogenic in practice with patients, health coaches as well. They're not patients, but clients. I want to underscore there's a whole lot of people using this in practice. And what I have to share with you here today is straight from the International Journal of Environmental Research and Public Health. And it's a review of low carbohydrate diets in the management of obesity and type 2 diabetes, a review from clinicians who use this approach in practice. So the three clinicians in this particular paper are Tara Kelly, David Unwin, you might have heard of him before, and Francis Finucane. They are from Ireland. Tara is. Looks like Dr. Unwin is from the UK, and then Francis is from Ireland as well. So isn't it crazy we don't have more of this kind of thing coming out of America? And I get it. Sometimes you put your medical credentials at risk when you try to stick your neck out on behalf of something like a dietary approach like low carb, when there's so many financial interests at stake with big food, with big pharma. So I get it. But I guarantee you, Dr. Eric Westman could have written a paper with Dr. Adam Nally and collaborated with a whole bunch of the practitioners. I could go down the whole list of all the practitioners in this country who use this approach. But here we have three of them saying, hey, look, this is what it looks like in clinical practice. So the abstract, this by the way was published in April of 2020, so just last month. Low carb diets are increasingly used to help patients with obesity and type 2 diabetes. We sought to provide an overview of the evidence for this treatment, considering epidemiology and pathophysiology of obesity and diabetes as it relates to your carbohydrate intake. We described the mechanistic basis for the clinical benefits associated with nutritional ketosis, and we identify the areas of practice where the evidence base could be improved. We summarize all the key principles which inform our approach treating our patients with low-carb diets. The scientific controversy relating to low carb is real, but is consistent with the known challenges of any dietary intervention and also the limitations of nutritional epidemiology. Don't get me started on the limitations of using epidemiology to tell you anything about nutrition. Literally, you can look at data, epidemiological data, which is kind of looking at a whole lot of studies all smushed together and saying, okay, what do we pull out of all these studies? You could literally make it say anything you want. That's been my concern about epidemiology for many years. International guidelines now recognize the validity and endorse the use of these low-carb diets as a therapeutic nutritional approach. I just did a Jimmy Rants the other day about how the American Diabetes Association just last year embraced low carb for the treatment of diabetes, and now, as of this year, Diabetes Canada has now embraced that as well. So we are seeing that happen with major organizations as it relates to low carb diets and chronic disease. We have found that early de-prescription of diabetes medications is essential, in particular lowering insulin and some other SGLT2 inhibitors. We encourage patients to eat to satiety rather than calorie counting. Furthermore, we monitor cardiovascular risk daily, or not daily, frequently. If they did it daily, that would be a little bit excessive. As with all patients with obesity or diabetes, but we don't necessarily consider a high LDL cholesterol as an absolute indication to stop these diets. We instead look at the LDL particle size and look for the larger LDL, which are not associated with an increase in cardiovascular risk. And in the absence of any kind of large randomized controlled trials regarding cardiovascular and other hard endpoints, we believe adopting a low carbohydrate diet is a legitimate and potentially effective treatment option for patients with diabetes or obesity. So if you're just joining us, I'm reading from a brand new review out of the International Journal of Environmental Research and Public Health. 3 low-carb doctors have decided to put together this review, low-carb diets in the management of obesity and type 2 diabetes, to show what it looks like in clinical practice. And again, this could happen in America. This could happen in places all over the world. I literally personally know, over 100 medical doctors that are using a low-carb, ketogenic, paleo, you name the diet kind of approach with patients. And yet you talk to most people and you talk about low-carb diets and you talk about the K word, ketosis, people still recoil in fear. Well, there's no medical doctor, blah, blah, blah. Or they go see their medical doctor and they say, hey, I'm doing keto. And the doctor goes crazy. Oh, we're worried about your cholesterol. We're worried about this, worried about that. And so people don't have a proper view of what this looks like within the clinical setting of a doctor's office. And so I'm really happy that they put this together, you guys. I hope you go look it up. It's from the April 2020 issue of the International Journal of Environmental Research and Public Health. Okay, let's get right into it. I don't want to really get into a lot of the introduction because you guys know about the prevalence of disease and the prevalence of obesity and other things. I want to kind of skip, and you don't need to know what a low-carb diet is. You know what a low-carb diet is. So let's look at what the nitty-gritty. Oh, this was kind of cool. So in the paper, they say, you know what? We need to define terms. So nobody's ever done this really, really well before, where they define what is a high carb diet, what is a low carb diet, what is a lower carb ketogenic diet. So they do that, they codify it in here. You ready for this? A high carbohydrate diet is anything that is more than 230 grams of carbohydrate, which is more than 45% of your total calories for the day. 230 grams of carbs at in one meal or one day worth of meals. Woo. My heart shudders at that because I haven't eaten that many in one day in over 15 years. Moderate carb would be 130 to 230 grams, which would comprise 26 to 45% of your calories. Low carbohydrate, this is where we get tricky with some of the terminology. A lot of people think low carbohydrate is that 20 grams. And we'll get to that one here in a minute. Low carbohydrate from a clinical perspective is under 130. So under 130 means anything below that 130, which is about 26% of your calories. And some people, especially within research circles, they look at about 25% of your calories coming from carbohydrate as being low carb. In fact, I've seen some of the studies have gone as high as 40 to 45% carbohydrate diets, and they call those low carb diets, low carbohydrate diets. Yeah, that's not low carb to me, but under 130 from a clinical perspective. But then ketogenic, which they call a very low carbohydrate diet, is anywhere between 20 to 50 grams of carbs, which is less than 10% of your total calories for the day. So I thought that was a nice little chart where they codified what the various levels of carbohydrate were for the different diets. Okay, so they looked at some of the observational studies, which I'm not really interested in looking at some of that, but I do appreciate where they got into various kind of things that they teach their patients. And one of the things that they teach their patients that their patients absolutely believe is that a calorie is a calorie is a calorie. And what that does to hunger versus the quality of the calories maybe not hurting hunger. All right, so let me read that aspect. Contrasting with the complexities and nuances of the nutritional epidemiology, the reductionist view that a calorie is a calorie and overall energy balance is what determines body weight appeals to scientists, clinicians, and the general public. However, perhaps this is way overly simplistic. It is, of course, true that weight gain is a manifestation of a relative excess of calories ingested compared to the amount expended. Indeed, this has been the basis for the isocaloric substitution of macronutrients in a whole lot of studies. In other words, when they are comparing a low-fat, high-carb diet to a low-carb, high-fat diet, they have to make them isocaloric to control that variable, which is true. The fallibility in the energy in, energy out adage has been highlighted by overfeeding studies where considerable inter-individual heterogeneity, I think it's just means you have a genetic predisposition, in the magnitude of weight gain is found in those exposed to relative caloric excess, reflecting variable activation of compensatory adaptive mechanisms. In other words, this whole notion that just everybody that overfeeds is automatically going to gain weight doesn't always happen. In some of these overfeeding studies, they don't. And then even in some of the underfeeding studies, participants don't lose weight, or they might even gain weight, and that confounds these people who think it's all about the calories. So they ask in this paper, what if the type of food ingested affects appetite and thus the calories in? Put another way, what if the calories acquired from eating, for example, potatoes, which is a higher glycemic index food, and acts in an equivalent way to glucose gels by elite athletes, which feature prominently in healthy eating guidelines, produces a very different physiological effect on dietary behaviors than, say, the same amount of calories from an avocado. If an individual is hungrier in the hours after the potato as compared to the avocado, then this isocaloric substitution approach may nullify potentially important differences between the effects on appetite, satiety, and eating behavior of different macronutrients. This is such a key point, you guys, because whenever you have these calorie apologists, they always say, well, a calorie is a calorie is a calorie, 1,000 calories of this is equal to 1,000 calories of that. I'm like, okay, go home, eat 1,000 calories of Twinkies, Ding Dongs, Doritos, and Coca-Cola, okay? And tell me how long it takes for you to get hungry. Now, you eat 1,000 calories. That's a lot of calories in one meal worth of that stuff. And it wouldn't take much to get to 1,000 calories between the fat and protein, fat and carbs in it. You get there really fast. And then test people's satiety, test their mood, see, here's the other thing. It's always about weight loss. It's always about maybe subjective things somewhat, but it's not always about how you feel. It's not always about how your mood changes. It's not always about satiety, how quickly you need to eat again. And so I think that stuff matters. And that's why this conversation about calories always needs to be redirected to what is happening to you when you eat those calories. Are those calories nourishing you and keeping you satisfied and keeping you happy and hunger at bay? All of those things are very good things. But if you're eating those calories and you're not having good digestion, you're having mental health issues as a result of it, you're depressed, you're angry because you start getting hungry again. None of that is ever factored into this conversation when it comes to calories. Many of our patients often report a reduced hunger and increased satiety after they change over to a low carbohydrate diet, something which has been studied in a lot of randomized controlled trials in which the low carb group was less bothered by hunger as compared to the low fat group, and it warrants further assessment in studies and trials. So it makes sense. Our theory is carbohydrates stoke an insulin response, which raises blood sugar, which increases things like ghrelin, which would make you hungrier. And so it makes sense. You go low fat, the default with a low-fat diet is a high-carb diet. It's the carbs driving that hunger. Whereas when you go low-carb, the default is a high-fat diet. Low-carb, high-fat keeps you full. I'm loving seeing these clinicians say, look at what happens in the real world. Let's not make this a debate, an esoteric debate of, well, which study is better, blah, blah, blah. It's about what is actually happening with patients. And they're saying, calories don't really mean everything, but the hormone response sure does. And we're seeing it on a daily basis. Now, they do talk about the limitations of interventional nutrition research. Randomized controlled clinical trials are the gold standard, but they're extremely expensive, and they usually have to be extremely small in nature because of that expense. Most of research is this epidemiology, which I've talked about many times here on Jimmy Rants, and a lot of it also is predicated on animal models, which are not complete when it comes to trying to make some kind of an assertion as to what happens to humans. And so if something happens in a mouse, it doesn't tell me what's going to happen in me. It just sets a theory out for them to test in a randomized controlled trial setting. This is what we can look at. All right. We should be cautious on relying just on randomized controlled trials or meta-analysis. One of the study authors has significant experience using different dietary approaches for type 2 diabetes and obesity. There are other controversies outside the scope of this paper as to nutritional epidemiology. And they question whether RCTs are indeed the gold standard. You cannot fail to mention the importance of patient choice. Like if a patient that just flat out says, I don't eat meat, what do you do with that person? You have to kind of meet them where they are. And so when you counsel a patient through any dietary intervention, you have to have those choices ready to go. Even if you think the best option is a ketogenic, low-carb, ketogenic kind of approach to help control diabetes and lose weight, if the patient is adamant about excluding some essential part of that ketogenic diet, you got to adapt to what the patient wants. And there are ways to do it. I know my Real Talk co-host, Dr. Will Cole, it's a podcast I do on Thursdays. Go listen today, by the way, llvlc.com. We talk about a lot of the common phrases that we use in the diet world, like a calorie is a calorie, calories in, calories out, you are what you eat, I'll start my diet tomorrow. We had a whole bunch of those, and we talked all about those. So go listen to that today, llvlc.com. But you got to meet the patient where they are. And Will wrote a book called Ketotarian, which is a mostly plant-based ketogenic diet. Now, he still includes eggs and fish, and there are a lot of vegetarian, vegan-type recipes in his book as well, but the main point is you've got to show people that there are various ways to get there. Now, you tell them, okay, this might not get you all the way there as a type 2 diabetic or as an obese person, but if you're going to stick true that you have to be mostly plant-based, here's how you do it well. And these clinicians, they have to work with those kind of parameters. It's a tough job. Dietary intake is influenced by many environmental, social, cultural, and economic factors. If we rely strictly on randomized controlled trial evidence, it does not allow us to take into account the critical influences of all these things on personal choice. Think about like someone from India who maybe their whole life they've never had meat, and they do it for religious purposes, and they choose not to include animal-based anything in their diet. And so you go see, or they come to see their doctor, hey, help me lose weight, I got type 2 diabetes, da-da-da. I think the first thing the doctor does is get them off the refined carbohydrates and get them on more real whole food-based carbohydrates, and maybe explain to them the value of healthy fats and the value of getting proteins in somewhere. If they could get eggs into the diet, da-da-da. You see how they have to like work with the patient where they are. The unfortunate part is, unless you're a nutrition-minded doctor, you don't give a crap about what your patient is eating. And it would come back and the patient would be like, well, my blood sugar's way out of control. And the traditionally trained doctor, the regular medical doctor that doesn't care about nutrition, well, here, take this pill, it'll control your blood sugar. You see how people stay stuck? in their diseased state, intentionally or otherwise. I don't think it's intentional. I think just a lot of these doctors, they're so in the mode of, all right, patient's got high blood sugar, let's give them metformin. Patient's got high insulin, oh, let's give them this insulin lowering medication. Patient still has high cholesterol, let's give them this cholesterol. You see how it works? And that's how traditional medicine gets to it. Rather than saying, maybe what you're eating isn't the best after all. If allocated to a diet we found unacceptable as part of an RCT, would they stick with it even a few months, let alone years, to give long-term evidence? So again, they're concerned about even some of the RCTs. So what are some of the putative physiological mechanisms associated with the low carbohydrate diet? It has been proposed that a shift from a paleo diet in recent history has driven the epidemics of obesity, diabetes, and cardiovascular disease. This would have had a relatively low proportion of carbohydrate with, apart from honey, a low glycemic index. By comparison, today's Western diet has a dense acellular carbohydrate intake with a higher glycemic index, which, among other things, promotes an inflammatory microbiome, which leads to leptin resistance and obesity. 20 years ago, there was a study comparing subsistence horticulturalist native Papua New Guinea islanders with North American controls, and they noted that their relative leanness and low burden of cardiovascular disease was associated with lower insulin levels. So carbohydrates had the greatest effect on these things. And that's been well known, you guys. Fat and protein, not as much. Protein has gotten a little bit of kind of a negative bugaboo because of some of the gluconeogenesis effects of having protein. But I think some of us are realizing carbs are the big one. Like, eliminate the carbs, lower the carbs down, and then fat and protein in their natural sources are probably pretty healthy. High insulin is also known to reduce satiety and influence eating behavior while downregulating lipolysis, which means the burning of fat. So a recent trial demonstrated that carbohydrate restriction is more beneficial for patients with higher insulin, and this is consistent with insulin influencing the so-called set point. This is where your body is trying to get to a set point weight, and it likes to stay at that weight. Let's see. Ketosis has been shown to attenuate the increases in ghrelin. That's the hunger hormone that makes you want to eat more. And thus appetite that occur with dietary restriction. And there is growing evidence in the role of therapeutic ketosis in weight loss. So the carbohydrate insulin model predicts that diets with lower carb and higher fat, but the same amount of calories as similar diets, except not low carb, high fat, would reduce insulin secretion, leads to an increase in fat mobilization and oxidation. Ultimately, this affects hunger and satiety, increases your body fat loss and your energy expenditure as compared with a similar diet of calories from a high carb, higher insulin secretion. So this theory was recently refuted in a meta-analysis of 32 controlled feeding studies by Kevin Hall. We talked about his study previously, where isocaloric substitution of carbohydrate for fat led to both reduced rather than increased energy expenditure and fat loss. However, we suggest that the same caveats as above should apply in discounting the effects of carbs as well as insulin or ketones on dietary behavior, and that a isocaloric substitution approach is probably a misleading fallacy. So they're repeating some of the challenges that I had to that Kevin Hall study, that it didn't really give a good methodology for comparing the two. All right, so he has a nice little infographic in here. I'm gonna show it on the screen and then I'll explain it. So there is the infographic about reducing your carbohydrate intake. When you do that, it reduces circulating insulin. Like, that's a telltale sign you've lowered carbs enough. Circulating insulin goes way down. And because of that, it reduces liver fat, which then reduces insulin resistance, which then helps to reverse type 2 diabetes. It also reduces insulin, which helps you lose weight, which reduces insulin resistance, which reverses type 2 diabetes. It also reduces insulin, reduces pancreas fat, increases insulin secretion, which helps to reverse type 2 diabetes. So I thought that was a very elegant little infographic that they made. So what are the clinical effects of nutritional ketosis? The influence of nutritional ketosis from very low carbohydrate diets on diabetes, obesity, and metabolic syndrome has been very well described in the literature. Overweight adults with atherogenic dyslipidemia who were on a diet for 12 weeks had favorable improvements in circulating free fatty acids and reductions in inflammation as compared to those on an isocaloric low-fat diet. So it's the lowering of the NLRP3 inflammasome. It inhibits the expression of that by the beta-hydroxybutyrate. So that's the ketone body, the primary ketone body in the blood. It also inhibits histone deacetylases, thus reduces oxidative stress, which is again another bad thing that promotes disease when oxidative stress is high. Mechanistic studies in humans and animals suggest that the infusion of beta-hydroxybutyrate improves the left ventricle function in heart failure. So I remember I was at one of these obesity conferences from these researchers, and there was one researcher that got up there, and he said, you know what, if I was having a heart attack, I would have them inject my heart directly with ketones. I was like, whoa. And so he kind of talked about the mechanism as to why and what the BHB would do. It's pretty fascinating. While the effects of the diet on hepatic steatosis are thought to be rapid and substantial, yes, I know it's a lot of medical jargon, but this is a medical paper, so stay with me, you guys. Don't lose interest. Suggests ketosis improves or prevents fatty liver. Many of the randomized evidence is currently lacking, so we need more evidence on that. Reports of reductions in blood pressure and hypertension, medication use going down in various studies, but we need to assess those more in prospective controlled trials. There is a good trial evidence that in patients with metabolic syndrome, going on a low-carb ketogenic diet is superior to any other diet strategy at improving lipid profiles. So if you have metabolic syndrome, if you have insulin resistance, which means you have elevated blood sugar, you have elevated insulin levels, fasted insulin levels, you have higher triglycerides, you have lower HDL cholesterol, you have higher inflammation levels. These are all the signs, you guys. Higher blood pressure, higher weight. All of these are signs that you have metabolic syndrome and insulin resistance. And so we know those people probably more than anybody. You've got insulin resistance, you've got metabolic syndrome, you have obesity. Those are the targets for a low-carb diet. Those are the ones that tend to see the best results when they try this kind of a diet. And they're seeing that in clinical practice. Arguably, though, the most significant and relevant therapeutic domain for the use of nutritional ketosis is in the treatment of type 2 diabetes. In a recent small trial of patients who were recently diagnosed with type 2 diabetes, after 90 days of consuming less than 30 grams of carbs a day, their weight loss was 9 kilos, which is around 23 pounds. Systolic and diastolic blood pressure reduced by 10.7 and 7.3 respectively. And their HbA1c, which is a key blood sugar marker, it came down from 8.9%, which is well into diabetes range, down to 5.6%, which is right there at the edge of you kind of want it 5.5 or below. But if they already had type 2 diabetes, bringing it down that much was significant. This study had 11 patients, no control group. So while the validity of the findings is not in doubt, their generalization and reproducibility remains to be determined. Well, let's see those studies. See, this is the problem. Whenever a study that's smaller like that comes out that proves the veracity in a few patients, the logical next step is, okay, we showed it in 11 patients, let's go get 500 patients. And let's see if we replicate it in 500 patients. Then you publish that paper, and then you go, okay, 500 and so you kind of go from there. Again, it's the expense involved with doing this kind of research that keeps researchers from doing it so often. So they did another randomized control trial in overweight adults with an HbA1c over 6. Those that were on the very low carbohydrate ketogenic diet compared to a moderate carb diet lost more weight, had much greater reductions in their A1C, and they stopped diabetes medication by 12 months. That's huge. A meta-analysis of 9 different studies suggested a low-carb diet, but not necessarily keto, helped patients with type 2 diabetes lose 1.18 kilo more weight loss and had a greater reduction in A1C than a normal and or high-carb diet. I'm not going to go over all this, but the point is we've got robust studies that are showing that if you have type 2 diabetes, keto, or at least a lower carb approach, is the way to go. And of course, it makes sense. What is the number one culprit in people with type 2 diabetes? You have elevated blood sugar and elevated insulin levels, and insulin that isn't working very well, and insulin resistance. Well, what's the best way to lower blood sugar, lower insulin, and improve your insulin resistance? It's a ketogenic diet. When I wrote Keto Clarity, and it came out in 2014, one of the chapters that we put in there is what do we have strong evidence for a ketogenic diet for? And the very first thing we put in there was type 2 diabetes. Because without a doubt, you want to eliminate the thing that's the culprit in all the reasons why your disease is progressing. You eliminate the carbs, you take away the instigator as to why type 2 diabetes doesn't get better. The funny thing is people are like, well, why don't doctors understand this? Well, they've never been taught this pathophysiology. They've been taught pharmacology. Oh, you got high blood sugar? Here, take metformin. Oh, you can't get it down enough. Oh, well, let's put you on insulin. And so that's kind of the way their brain goes. And now we have clinicians, and I love this paper, that are saying, here's how it works in the real world. Here's how we make it work. It is important not to dismiss the findings from well-conducted studies, bearing in mind that inferences around efficacy, effectiveness, and safety need to be tempered by the study design. Study design is everything. Like I said with the Kevin Hall study a couple of weeks ago, his study design sucked so bad, and I offered the ways in that Jimmy Rants all about how he could have improved it. And so that has to be taken into effect. Criticism of low-carb and ketogenic diets is still widespread and pervasive. I've heard that somewhere. Ever since early descriptions of their use, one recent commentary noted negative results from randomized controlled trials of this. However, the risk of type 2 statistical error may be significant. In one study, 60% of patients dropped out of the low-carb arm at 2 years. Difference in weight loss was negligible, may have been due to a lack of statistical power and not efficacy. Furthermore, it is worrying that the supervising author was an investigator for a competing weight loss program, Weight Watchers, which was not disclosed in the paper. This is the other thing. When they're starting to take a look at and analyze a lot of the studies looking at low-carb diets, and there's a negative one, I almost want every single negative one to be scoured for controversy, for someone that has a vested interest. Because if you don't disclose that you work for Weight Watchers and yet you're a part of a study trying to prove or unprove the veracity of a low-carb diet, how credible are you? Not very. Another negative low-carbohydrate trial had only 26 participants from a single center, and while the duration of follow-up was 2 years, the low-carb intervention only lasted 3 months. This is another one. When they do these studies where they give them guidance for a period of time, in this case 3 months, and then they're like, all right, you're off the hook, eat whatever you want now. But then they still call them low carb when they keep looking at them for a year and 2 years out in this study. But they only guided them with low carb for the first 3 months. Well, if you tell people they could eat whatever they want, why would they stick with low carb unless they were seeing great results and they wanted to keep that going? But if the researcher doesn't give them any guidance, you can't really use that. All right. So they give some tips for other clinicians who want to use a low-carb ketogenic approach in their clinic. Here are some considerations. All of this controversy and uncertainty is reflected in the clinical practice of even the most qualified expert of all to provide therapeutic nutritional intervention, the dietitians. A recent survey of their clinical practice in the UK found that about half of dietitians advise patients to restrict carbs. That's a lot higher than I would have ever imagined. I'm sure here in America, or as I've talked about before, we want to see where the worst dietitians are in the world. Australia's number one. They think they're God when it comes to diet advice. And they hate anybody that does not toe the line of what they say. And if you go off the line of what they say, then they come after you. It's bad in Australia. You Aussies, you can tell me all about it. And Canada is really bad as well. Now, here in America, they're bad too, but they're especially bad, Canada and Australia. So the fact that in the UK, 48% of them recommend it occasionally or frequently was shocking to me. 35% of them say they would consider 30 to 39% from carbohydrates being more realistic. Reflecting on our own extensive combined clinical experience with low carb, with obesity and type 2 diabetes, we identified the following 5 points of consideration. And so, let's see, did I get it out of order? Nope. Doctors, nurses, and other healthcare professionals ought to be aware that the use of low-carb and ketogenic diets in patients with obesity or type 2 diabetes is in fact supported by many sets of guidelines from international bodies and professional groups. So we talked about this just yesterday. The most recent guidance from the ADA is unequivocal in stating that reducing overall carb intake for individuals with diabetes has demonstrated the most evidence for improving glycemic load and may be applied in a variety of eating patterns that meet the individual's needs. That was reciprocated by Health Canada recently as well. All right. Although research data are relatively scarce on optimal patterns of medication usage early in low carb and keto, we have found that early and intensive de-prescribing is often required, particularly in patients with diabetes. So the caveat with this whole conversation of looking at diabetes, specifically type 2 diabetes, is people should not willy-nilly go on a low-carb ketogenic diet on their own. So if they come or go to see a doctor, the doctor's going to see really quickly they come off of medications, they come off of insulin very quickly, and that needs to be closely monitored. A rapid titration of insulin is obviously important in order to prevent hypoglycemia, which we talked about yesterday. In general, we tend to stop all fast-acting insulin at the time of initiation of a low-carb ketogenic diet. And if not stopping basal insulin completely, we do reduce the dose by about 50 to 80%, which is a pretty significant drop, which tells you the insulin is there for the sole purpose of dealing with the carbs that you didn't need to eat to begin with. Pretty fascinating, right? So this mandates 4 times daily monitoring of blood glucose. So you can get a continuous glucose monitor put in your arm and you can constantly see how it's going, or prick your finger all throughout the day. We have found that it is essential that these patients have immediate access to a nurse, primary care doctor, consultant, dietitian with experience with low-carb diets, especially in those first couple weeks. So when you start keto, low-carb, you drop your carbohydrate intake. Let's say you were eating, say, 500 grams of carbs, and then suddenly you go down to 20. Yeah, you a type 2 diabetic, you're going to have you're going to have your needs for medication and insulin go way, way down right away. In addition, we tend to stop sulfonylurea. I know I'm slaughtering it. It's the sulphonylurea. Somebody else pronounce it. I'm not a medical doctor. I'm just reading from a medical journal. At the time of low carb starting, to avoid the risk of hypoglycemia. We also tend to continue using metformin because it gives an insulin sensitizing effect. It also gives cardiovascular benefits and is a very low risk of hypoglycemia. Metformin is one of those ones that they do keep you on for a little while because you do improve insulin resistance with metformin, which I know some people, even without type 2 diabetes, have considered taking metformin as a way to continue that healing of the insulin resistance. The only thing, and I did a recent Jimmy Rants about this as well, is they have some suspect ingredients in metformin that an independent analysis looked at that. So go back and watch that Jimmy Rants that I did probably about a month ago. I did that Jimmy Rants about some of the problems with metformin. All right, so let's keep going down the high blood pressure medications they also have to titrate down on as well. All right, calorie counting not required. We talked about that one a little bit earlier. You want to monitor cardiovascular risk factors. So LDL is not the way to do it. You want to look at blood pressure. You want to look at the general lipid profile, specifically the triglyceride HDL ratio. You want to look at A1C. All of these will give you relevant data as to how low carb keto is working. They also say to ensure adequate fiber intake, getting about 30 grams of fiber a day is what they recommend. The average is around 18 grams. So definitely when you reduce whole grains on a low carb diet, it could make that deficit even worse. However, we found in practice that going on a low carb diet, which limits all these ultra processed foods, but it also includes nuts, seeds, non-starchy vegetables, as well as some low carb fruits, can lead to a net gain of fiber rather than a reduction. So if you just eat the natural foods that come along with a low carb ketogenic diet, then that will happen naturally. All right, let's see. So their conclusions, and I want to hear what you guys have to say. Current guidelines support the use of low carb diets as an alternative to the standard low fat calorie counting advice for those patients with obesity and type 2 diabetes. In patients on multiple medications that hold polypharmacy and or on insulin who have multiple dietary restrictions or other comorbidities like renal disease, low carb diets should be supported by experienced healthcare professionals as well as a specialist dietitian who understands nutritional ketosis. Clinicians should continue with regular surveillance and the management of all risk factors even once diabetes goes into remission. The need for a large multi-center randomized controlled trial with cardiovascular and other endpoints, as well as feasibility and cost-effectiveness analysis, seems to be warranted and worthy of prioritization. In particular, it should be noted that as with any other dietary intervention, the evidence for long-term compliance with and sustainability of carbohydrate restriction is currently not as strong as we'd like. So in the absence of higher level evidence, existing data suggest that adopting a low carbohydrate diet is indeed a legitimate and potentially very effective treatment option for patients with diabetes and obesity. Again, if you joined us late, this is in a medical journal now. It was published last month in April in the International Journal of Environmental Research and Public Health. The title of the paper, Low Carbohydrate Diets in the Management of Obesity and Type 2 Diabetes, a review from clinicians using the approach in practice. Tara Kelly, David Unwin, and Francis Finucane were the three authors on that. So good news, you guys. Like we always hear, we don't have any evidence. We don't have enough evidence. Doctors will say, well, we don't really have evidence of ketogenic diets. I want you to print out this review and say, this explains how to do it in clinical practice. I'm almost tired at this point of hearing doctors say, well, we don't have enough evidence. Oh, well, nobody's really using that in practice. Oh, ketosis is dangerous. Oh, just take your damn medication and shut up already. That's kind of the tone you get when you try to bring up the low carb word or the ketogenic word. And quite frankly, I think the 1980s called and they want their dietary advice back because we're in 2020 and keto is here to stay. All right, let's see what you guys have to say. We're going to pop over here to my Instagram page first. Then we'll pop over to Facebook and finally to my YouTubers. Thank you all for being here today on Jimmy Rants, jimmyrants.com for all the past episodes. Hello, you guys. Come on in. Lots of people here today. Thank you guys for watching, and you're dumbfounded because not one single comment. I will come back to you. I'm going to let you think about things you think about that. Maybe you just kept doing a whole lot of amens out there while you were listening to me read that. But it is fascinating that it's confirming what so many of us have done on our own with low-carb ketogenic diets. We've done all this on our own. We didn't need a doctor to tell us to do this. We didn't need any dietary guidelines to tell us to do this. We just started it. Maybe you read my book, Keto Clarity, or some other book, and you learned about it and you started doing it. And so, but it's cool to see that in clinical practice, they're actually using this. All right, let's go over to my Facebook page. What's up, guys? See what you have to say on this one. Tracy says, what makes me mad is I was criticized when I was heavier for not losing weight, but then I got criticized on how I lost my weight, or I got criticized on the fact that I did not lose weight fast enough. What's that phrase, Tracy? You're damned if you do, you're damned if you don't. So, yeah, it's unfortunate that we are shamed as patients. Like, I know I've been a big boy my whole life. And you always hear the doctor kind of try to sneak it in. Well, you should cut your calories and cut your fat and lose some weight. They're almost like ashamed to talk about it. And I've been at some of these obesity conferences with a whole bunch of doctors, and they would have whole seminars on how do you talk to the patient about their obesity problem. Well, number one, don't tell them they're obese. That is horrible. Don't tell a fat person they're obese. But then, yeah, they try to shame you in that. But then when you do lose weight, well, you use the wrong diet. I remember after I went on the Atkins diet, I went to see my doctor. He's like a mile from here. And I went to see him, and he was like, whoa, you lost a lot of weight. It was 180 pounds in 1 year. Yeah, how'd you do it? In the Atkins diet. And I was like real hesitant. And he didn't say, congratulations. He said, we need to check your cholesterol immediately. So it was like this judgment almost that I didn't do it the, quote, right way. And he even made the point, well, you lost too much weight too fast. So yours was criticized for not losing fast enough. You certainly can't win in that discussion, and it's unfortunate. And even like people will have well-meaning comment, oh, you've lost too much weight, you need to stop losing weight. And of course, it's your journey. It's none of their business. Tell them to buzz off. My doctor was very happy when I decided to go low carb. He knows how much I struggled. I have been happier than ever doing it. Well, good. Keep doing it. Rhonda says, interesting that years ago I had a horse with EPSM, equine polysaccharide storage myopathy. The treatment was a high-fat, low-complex carbohydrate diet. It is difficult to get that much fat into a horse, but Cornell found that this diet for a horse had no negative effects, and that's a completely plant-based animal. So yeah, I also use the whole, how do we fatten up a cow? How do we fatten up pigs? They basically fatten them with grains. And so if you're fattening up a cow with grains, which is very high in carbs, why wouldn't it make sense that you would also fatten a human by eating a lot of carbs? The other one is, was it foie gras? I'm going to mispronounce lots of words today, but that delicacy where they force feed corn to blow up the liver, basically give a fatty liver to this bird, and then people eat it. So they got fatty liver, force feeding them carbohydrate. So why would we not think that fatty liver, by the way, is another one of those signs of insulin resistance? Why wouldn't we think that's what would happen to humans? So it is amazing in the animal kingdom that a low-carb, high-fat diet would certainly do wonders if they were trying to make them lean. Post a link to the study you referenced, said Brian. I don't have a link per se. It is published in the International Journal of Environmental Research and Public Health. So you can just Google that. And then it's from the April 2020 edition, April 8th, 2020. And the title is Low Carbohydrate Diets in the Management of Obesity and Type 2 Diabetes, a review from clinicians in clinical practice. Okay? Yeah, I don't have a link. It was, oh, here it is. mdpi.com and then /journal/IJERPH. So there is the URL. I know it's backwards on your screen, but try to take a screenshot and then like translate backwards, but go look it up. Good stuff, right? Rebecca says, I know we're not supposed to tell people we are fasting, but anytime I let it slip, people think I'm going to die. Oh, girl, you're on a whole nother topic that yeah, I could definitely wax for hours on all the things that people say back to you when you tell them you're fasting, even when you tell them you eat keto. Oh my God, all that meat's gonna kill you. Oh my God, are you worried about all that fat clogging your... Yeah, trust me. All right, thank you, Facebook. Let's pop on over to my YouTubers. Got a bunch of you on here today. Thanks for being here today. All right. Roz says, hi. I'm late, I'll have to rewatch. Thank you, Shirley, for being here. Ryan says, brought my A1C down from 11 to 4.9, no medications, just eating 20 grams of net carbs per day, 30 minutes a day of walking, lost 6.5 pounds, or 65 pounds. Sorry, I thought that was odd. And I don't even intermittent fast. That is so, so awesome. You go, go, go. That's cool, man. Good job. All right, let's pop back over to Instagram and see if Kat doesn't have their tongue anymore. I have literally done almost 500 Jimmy Rants and literally have never come to Instagram and have no comments to talk about. You guys are usually chatty Kathy, so let's see if anybody... Oh, I got one! I got literally one comment. Thank you, Dana. You saved the day, and thank you to you guys. Other than that, I wouldn't have anybody to talk to, so... You still have time to get a few comments in. Dana says, I fell off the keto wagon for the past 4 months, back on, and my heart of happy listening to you again. Well, welcome back into the fray. And it's good to know that this isn't just a willy-nilly diet, that people are trying and there's no science or there's no clinicians supporting it. There's a lot of science that supports a low-carb ketogenic diet. And this is just the latest, you guys, of proving that there is veracity to a low-carb diet. And when you do a clinical review of all the studies and all the research that's out there, it's not perfect, but it's enough to say, you know what? We know we have good evidence that supports using this approach, especially for those with obesity, especially for those with type 2 diabetes and insulin resistance, which is most of the population. You look at obesity, type 2 diabetes, and insulin resistance, that's probably 80% of the population. And so, I don't know why this isn't more ubiquitous. But you guys know, I've been out here a very long time promoting this message, and I'm not going anywhere. I'm gonna keep pushing it hard, I guess until everybody believes it. Joey says, what are your thoughts on the drug prednisone? That's kind of a weird one to throw into this Jimmy Rants. In general, I think steroid drugs are targeted for specific reasons. My mom takes prednisone for her myasthenia gravis, and it prevents her from losing weight, and it's very frustrating. So not a big fan for that, but if you can find alternatives that don't have the weight gain, it's probably okay. But I guess in general, for the right circumstance, is probably okay. Life and pics, family and friends poo-poo all my keto ways, but I don't have type 2 diabetes. Exactly. See, this is the thing. They're like, why are you cutting your sugar? You don't have diabetes. I'm like, you realize I don't want to get diabetes? Like, I have a family history of heart disease. My brother died of heart disease at 41. My dad had a heart attack at 48 and 50, and quintuple heart bypass surgery at 54. Both of my grandfathers dealt with issues that led to an early death with their heart issues, early death in their early 50s. I'm 48. So I'm bucking a lot of trends right now, trying to prevent that. And so diabetes, heart disease, cancers, on and on and on, are all tied back to the same disease, and it's the disease of insulin resistance. So people might poo-poo you, and I'm sorry that's happening, Life in Pics, but I think you hold true to what's going to make you healthy, and that's all that matters at the end of the day. We don't need validation from friends and family to do keto and know why we're doing it. We just need to know, okay, is this working for me? Yes. Is it making me healthy? Yes. What else do you need? Stick to your guns, stick to what you know works for you, and never waver. That's it for this episode of Jimmy Rants. JimmyRants.com is the website. As always, you want to engage live in the content, you got to go follow me. I'm right here on Instagram. I am at Living Low Carb Man, LIVIN LOWCARBMAN. Joey says, that's why I asked, because I can't lose weight. I've been on keto carnivore since August 2nd of last year. My weight has not budged. I do feel better though. Oh, you're taking prednisone. Yeah, if you could figure out a way to not be on it, you're going to struggle with weight loss as long as you're on prednisone. So good luck to you, buddy. So if you missed the live, we also simulcast over here on my Facebook page. So thank you guys for being here. Also over on my YouTube stream, we come on here as well. We love everybody in the Jimmy Rants family. So thank you guys for being here today. If you missed the live here on Instagram, you can watch it on replay over on IGTV. So go check it out, you guys. I usually, when this is over, after I get done talking to Facebook and YouTube, I put show notes in there, and it actually goes up right on my page. So you can always see the older episodes right there on my Instagram page. We also throw the past episodes up at JimmyRants.com, as well as over on YouTube. Type in a keyword, Jimmy Rants. You will find the show. So guys, that's it for now. Until next time, we'll see you then. That is a wrap. Download video. I love it when people come on and you're about to sign off. You see people come in and it's like literally 2 seconds left and you're just like, oh man, they came in. Oh, okay, bye. I've done that many a times where I see a friend is on a live, and so I will go in and they're like, okay guys, until next time. I was like, I guess I missed. You do what you got to do. But thank you guys for being here today. Always fun to hang out with you. Let me pop off of here for now. Cindy says I missed it. Well, watch the replay, Cindy. That's why I do it in multiple places, on Instagram, on Facebook, on YouTube, a live stream on YouTube. We also throw an archive form on YouTube. You're never going to miss any episodes. You can always go to JimmyRants.com and you'll definitely never miss a single episode. Sorry you missed the live and you weren't able to engage. So a lot of people, they like to watch the live because you get to interact with me and in real time talk about things. So sorry you missed it, but definitely watch the replay. But let me pop off of here for now. Like Sandra, you're a perfect example of what I was just talking about. I'm about to say goodbye and here you pop on for the first time. So sorry, but until next time, guys. That's so cold, isn't it? I am popping off of here for now. So thanks for watching, guys. We'll be back again soon. Bye. Bye, guys. Thanks for being here.